Just a second, let me start the recording.
Okay.
Okay. So, hello everyone, welcome to the meeting. Welcome. Okay, and then we can start if the team is ready. And we will show you guys. Thank you so much.
Thank you so
I'm going to share the screen for the agenda for today. Now it's yours. Then guys, go ahead.
Hello, everyone. I hope everyone is having a good evening or morning. Today, our Lyme group is presenting. Our first topic is going to be about pain management in older adults with Dr. Gamila and Dr. Tayseer. Dr. Gamila and Dr. Tayseer, and if you're available, please go ahead and start presenting.
I think they didn't join us. If Asma, we can start with our topic and then I think they...
Sure. Let's do that. Let's start with food disorders in older adults. I'll start presenting that subject actually. Dr. Nader, if you can, yeah, thank you.
I'll stop the sharing. You can go ahead. Thank you, everyone.
Yeah. Okay. Sorry, can everyone see my screen? Sorry, this is...
Yes, we can.
Awesome.
Yes.
Okay, so we're going to be talking about disorders of the foot. The subject or the objective that we have today is to discuss the role of primary care clinician in foot care, common deformities of the foot, skin and nail disorder, systemic diseases affecting the foot and ankle. We are hoping that by the end of this, everyone will be able to describe common structural deformities, how to recognize and treat problems of the foot, and also identify patients that are candidate for surgery of the foot deformities. So, so let's discuss why is it important why is it important part of geriatric health? Well, for a couple of reasons, because 1/3 of older adults, they have foot pathology, which this is also higher in patients that are hospitalized or that are in a nursing home due to lack of flexibility and being unable to assess their own feet. So this falls on the clinicians to assess their feet and refer to pediatric care if necessary. Also, this can have significant effect on their quality of life, negatively impacting it if it causes long-term sequel or long-term complication. So most of the common deformities derive from a long-standing effect of pathological foot and abnormal distribution of weight between during walking and other movement. This causes stress on musculoskeletal structure of the foot, and over extended period of time, this can cause arthritis, tissue atrophy, and subluxation of foot joints. Next, we're going to talk about some of the most common disorders. Collapsing pes Plano valgus. This is generally seen in foot with unstable medial longitudinal arch. The high arch usually collapses over time, leading to flat feet. This results in subluxation of the joint and leads to arthrosis. With age, also the foot becomes rigid, and an accommodative orthosis can absorb the abnormally high pressure. Other associated deformities can include posterior tibial tendon dysfunction, bunions, chronic dislocation of the joint, Hamartos, and Neuromas. Cavus foot or high arch, usually they are rigid and very poor shock absorber. This is associated with metatarsus adductors, and older adults generally lose the fat pad in both the heel and the submetatarsal head region of the foot. Associated other deformities include Hallux Hamarto, sagittal dislocation of the metatarsal phalangeal joint, metatarsalgia, midfoot dorsal extosis, and rigid Hamarto deformities. These two are one of the common one of the common complication or disorders of feet. This is high arch. When the high arch is usually higher than normal, it can lead to pes cavus, which commonly associated with neurological changes. In older adults, the excessive pressure placed on metatarsal head on the long term can cause pain and ulceration. A flat arch on the other foot, this can lead to collapse in pes Plano valgus and flattening of the medial longitudinal flat feet, along with pronation, which is demonstrated here by lateral deviation of the Achilles tendon and outward rotation of the deformity of the foot. Equinus, commonly seen in pes planus or cavus foot, but it also can be seen in other normal appearing foot. Patient can bear most of their weight on the toes when walking because of the deformity. The deformity prevents weight bearing on the heel of the foot. It also may involve tightness of either the gastrosoleal complex or the gastrocnemius muscle. It can cause various conditions, including Achilles tendonitis, plantar fasciitis, metatarsalgia, and Hamarto deformity. Next, we're going to go into discussion of some or definition of some of the disorders of the foot. Here in foot disorders, we have Banyan. Banyan is a prominent and dorsal medial eminence of the first metatarsal. It's usually associated with Hallux Valgus and which is a deviation of the tip of the great toe or main axis of the toe toward the outer or lateral side of the foot. Digiti quinti varus, this is a valgus displacement or splaying of the fifth metatarsal. It results in varus or inward deviation of the fifth toe. Dislocation of lesser metatarsal phalangeal joint, this is quite obvious. It's a progressive loss of capsular and ligamentous constraint of lesser metatarsal phalangeal joint. It allows dorsal, medial, or lateral subluxation and dislocation of the digit. And then next we have Hallux Valgus, which is an alternative clinical diagnosis for Hallux Valgus or a Banyan. There is a varus plane of the first metatarsal with valgus or rotational deformity of the phalanges of the great toe. Also for disorder, we have Hallux Limiters and Rigidos. This is a degenerative joint change, involves the first metatarsal, it results from dorsal spurs, and it has marked limitation and absence of any range of motion. The difference between Hallux Limiters and Rigidos, this is based on radiographic interpretation. And then Hamarto. Hamarto is a muscle tendon imbalance. It causes contraction of the proximal or distal interphalangeal joint for both. Taylor's Banyan, this is a prominence of the dorsal lateral aspect of the fifth metatarsal head. Valgus position, this is frontal plane position in which pressure is inwardly directed to the foot. And varus position, this is a frontal plane position in which the pressure is outwardly directed in the foot. So they are quite opposite to each other. Next, we have midfoot disorders. We have metatarsalgia, motor neuroma, and tibialis posterior dysfunction. So metatarsalgia is a pain in the forefoot near the head of the metatarsal. Motor neuroma is a congenital shortening of the first metatarsal shaft. It creates an abnormal metatarsal arc. Excessive weight is placed on the second metatarsal head during gait and stance. And this dynamic is pathomechanic of the foot, which is modified and can lead to Hallux Valgus, Abductor valgus, or rotational deformity of the hallux. Tibialis posterior dysfunction, this is a chronic rupture or weakening of the tibialis posterior tendon. This is secondary to long-term pes planus. And then we have the rare foot disorder. We have calcinial spur. This is a calcification of the attachment of plantar fascia. It's usually at the medial plantar tuberosity of the calcaneus. The spur projects anteriorly, and the consequence. This is the consequence of chronic repetitive trauma or stress resulting from biomechanical and pathomechanical change. When the ligaments calcify, inflammation and associated pain at the attachment result. This may be referred to as heel pain syndrome and may be related to plantar fasciitis. Equinus is a tight Achilles tendon, and Haglund deformity is hyperostosis of the posterior and superior portion of the calcaneus, enlarging the calcaneus. In turn, it can cause pressure on the attachment of the Achilles tendon. The presence of the deformity also can produce pressure area of the heel to count the counter of the shoe. It's easily demonstrated on lateral radiograph of the foot and can be associated with tendinitis or bursitis. Then we have plantar fasciitis. This is a common inflammation and pain involving repetitive microtrauma of the plantar fascia, particularly at its posterior calcineal attachment. It's associated also with biomechanical and biomechanical changes in the function of the foot. It's related, as we said, to calcinial spur, ligamentous calcification, and tissue atrophy. Plantar fasciosis is a degenerative condition, causes heel pain that describes non-inflammatory phase of the heel pain. It's caused by degeneration of the plantar fascia, usually as a result of repetitive stress. Then we have tarsal tunnel syndrome. This is an entrapment neuropathy of the posterior tibial nerve. Then we're going to discuss some of the common disorders. Cystic erosion. Cystic erosion is area of radiolucency. It's usually noted on X-rays with arthritic change. It happens with arthritic change like rheumatoid arthritis. It's seen in the metatarsal head and associated joint changes. Entrapment syndrome occurs when the nerve is compressed by ligaments or other soft tissue inflammation. It results in pain and possibly numbness and neuropathic symptoms, like we said a little while ago, metatarsal tunnel syndrome. Most common sites are the posterior tibial nerve and intermetatarsal nerve. Periostitis is inflammation of the periosteum. Subluxation is a deviation of the joint position, and tenosynovitis is inflammation of the synovial sheath of a tendon complex. Sometimes it's associated with tendon tear. Next, my colleague, Dr. Islam, will be talking about the management and go into more details about the common disorders of the feet. Go ahead, Dr. Islam, I'll present if you're here.
Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Good morning, everybody. Good morning, Dr. Nader. My name is Islam Mohamad, coming you guys live from Mile High City, Denver, Colorado. I'm going to present the mostly common foot disorder, and I would like to share my screen. Okay, share. I will try my best to control my nerves. It's so hard. Great job, Dr. Asma. Great job.
Thank you, you got this.
Thank you, my dear. Okay, so guys, can you see my screen?
Yes.
Go ahead.
Yeah.
Yes. Okay. So I'm going to talk today about the associated deformities. So the first associated deformity, it's dislocated of the metatarsophalangeal joint. So it is actually the end stage of the Hamarto in a chronically dislocated metatarsophalangeal joint, generally on the top of the metatarsal head. So it is a common source of chronic pain and can cause plantar ulcerations as well. And the treatment usually conservative, but if the conservative management fails, then we will go for surgery. So the conservative management included shoes with high toe box. As we can see in this picture, this condition occurs when the second toe, usually associated with Hallux Valgus, can result in crossover toe deformity. So next, I'm going to discuss the Hallux Limiters. So we have two types of Hallux deformities, Limiters and Rigidos. The first one is Hallux Limiters, which is arthritic condition of the first metatarsophalangeal joint. The physical examination, including crepitus and decreased range of motion. Joint essentially function as if it were fused. So conservative management consists of orthosis and which prevent motion at the first metatarsal of the first metatarsophalangeal joint, thereby relieving pain. Surgery can successfully reduce symptoms and increase functionality. And here, as you can see, first we required the patient to have an X-ray to determine how much arthritis and how much bony spurring is present. So this is the normal range of motion. As you can see in this picture, dorsiflexion of the big toe. And this is the Hallux Limiters. You can see there is limitation of the dorsiflexion of the big toe, and Hallux Rigidos, there is total, failure to dorsiflex the big toe. Next, it's Hallux Valgus or Banyan. It's a very common disorder. It affects 1/3 of population above 65 years old. It is a subluxation of the first metatarsal phalangeal joint, resulting in abduction in the first metatarsal and abduction of the hallux. It can be painful and frequently is arthritic. Conservative management include like instructing your patient to wear shoes with wider toe box and using padding. And the surgery if the deformity is symptomatic or unresponsive to conservative management. Next, this is the bunion. As you can see, this is the normal foot, and this is the initial stage, and this is the pronounced deformity. So this deformity progressed throughout person's life, leading to hypermobility of the first metatarsophalangeal metatarsal cuneiform joint. In most instances, usually the most commonly or the most effective treatment is surgery, and there is so many kinds of surgery, but the most famous one is the bunionectomy. So we take the ligaments as well as part of the bone, and we restore the functionality of the joint. So in most instances, this positive outcome was seen regardless of the surgical approach. As we said before, there is so many types of surgery to correct bunion. Okay, and now we have the Hamarto, which is buckling or contraction at the proximal interphalangeal joint or the distal interphalangeal joint of the lesser toes. It can be flexible and easily reducible, and it can be rigid and non-reducible. Treatment, padding of the affected area, and wide box shoes, custom shoes, debridement of the callus or surgical correction. Okay, and now we have Hamartos are caused by muscle tendon imbalance around the, so we have like another disorders of the Hamarto. This is mallet toe and claw toe. So Hamarto, it is caused by a muscle tendon imbalance around the metatarsophalangeal joint. In a classic Hamarto, what we're going to see is flexor contracture at the proximal interphalangeal joint, but the distal, you are going to see it as extended. So in mallet toe, which is the Hamarto that contracts at the distal interphalangeal joint, claw toe, it's a Hamarto with contracted distal interphalangeal joint as well. So it is a Hamarto that contracts at the proximal interphalangeal joint and the distal interphalangeal joint as well. So as you can see, this is Hamarto. This is the distal interphalangeal joint. You're going to see it as extended or, it's not contracted, but the proximal interphalangeal joint is affected, as you can see here in the picture. But the claw toe, both of them are contracted. The most successful kind of surgery for Hamarto is K-wire fixation. Now, and this is neuroma, and this is probably very common in females who love to wear like very tight shoes and they walk barefoot on solid grounds. So neuroma, it's actually is not a typical neuroma, but it is degenerative disease of neurological degeneration of the interphalangeal nerves. So it is a benign growth of the peripheral nerve caused by chronic entrapment. Seen in foot between the third and fourth metatarsal heads, we call it, another name of it, it's Morton neuroma. Usually the conservative treatment is successful with metatarsal bag or orthosis and single injection of a local anesthetic lidocaine 0.5 ml and glucocorticoids methylprednisone 20 milligram or 0.5 into the side of the tenderness, and can be performed use the dorsum of the foot, not the plantar. So surgery, release of the intermetatarsal ligament or primary excision of the neuroma. Next is the posterior tibial tendon dysfunction. And this is a gradual tearing or rupturing of the tibialis posterior tendon. Okay, it causes collapse of the longitudinal arch, which leads to subluxation of the rear foot and eventually the ankle joint. As you can see, there is loss of the arch of the foot. And this picture shows stage 3 tibialis posterior dysfunction. This is how it looks like from the lateral view. And rupture, and it's very important to note that rupture of the posterior tibialis tendon can easily be missed because symptoms of this injury resemble symptoms of the normal ankle sprain. Some physician may feel that posterior tibialis rupture is a rare condition, one that they have never seen. Now we have, this is a treatment of the posterior tibialis tendon rupture, usually conservative management with orthosis or bracing, and with ankle foot orthosis or custom brace. And the surgery, it has the most successful rate. So as I've mentioned before, this deformity, it has stages, stage 1, 2, 3, and 4. So stage 1, there is only tendinitis, but without deformity. So the patient will come symptomatic, like there is pain in his foot, but without any deformity that you can elicit during the examination. So the treatment here is synoviectomy and repair of the tendon. And then stage 2, it is tearing or rupturing of the tendon. Deformity is flexible and fully reducible. And here we do, the surgical treatment will be calcaneal osteotomy and tendon transfers. Stage 4, it's deformity. The deformity here, it's rigid and arthritic. And here we need to do arthrodesis of the rear foot. And the stage 4, which is valgus ankle deformity, and we do plantar arthrodesis. So the last deformity or disorder of the foot in elderly is heel pain. Okay, so we have two causes of heel pain, which is plantar fasciitis and heel pain while walking. So plantar fasciitis, as we know, it's a painful heel on walking after rest. So it is like the first step in the morning, you are going to feel the pain in the first step in the morning. So after prolonged rest. Initial therapy, it's NSAID, steroid injection, or physical therapy. Second, it's preventive therapy, which is reducing the ligament strain and with inserts, night splints, or stretching exercises. So this is totally the opposite. Heel pain while walking. This here, heel pain relieved by walking. Here, this is heel pain while walking, which is symptoms increase during barefoot ambulation and decrease with the use of the cushioned shoes or inserts. The only treatment is accommodative insert, which acts as external shock absorber. So it's important to note that heel pain while walking, the treatment is like padding or cushioned shoes, which is totally the opposite for plantar fasciitis. If you use this kind of shoes, it will increase the symptoms of plantar fasciitis. Thank you so much, guys, for listening. And if you have any question, please feel free. We have like 2 minutes before Dr. Hina start her presentation.
Thank you both. Thank you so much. This is really great, excellent presentation, concise to the point, and I think it's important. And the importance is not only for you guys as physicians. Hopefully, when you go to the residency and you see your patients, you can evaluate the treat and identify these possible conditions, refer them to surgery or advise them about the insert or the shoes. But also, I think around your family members, your elders, your friends and their families, you can advise as well. This is one part of the goal. The second part is for ourselves as we get older. Every one of us one day will be going through some of changes. So it's an advisable thing to do when you wear your shoes. Identify which shoes is good for you for a long time. So if you are wearing a very tight shoe for a long time, it will definitely make some changes in your feet. So just it's a preventable approach for all of us. Thank you.
Thank you so much, Dr. Nader.
Thank you for
Okay, hello everyone.
hello.
So thank you so much, Dr. Islam, for your wonderful presentation. It was really informative. And guys, let me share my screen first. Okay. So my name is Hina Zubair, and from now we are here to discuss about the general conservative management. So first we have to do like accommodate a foot deformity or alter foot function to relieve the physical stress on the certain portion of the foot. It is either by temporary felt padding or silicone putty spacer, or either by the over-the-counter devices which we use to place in the shoes. So the over-the-counter devices, they are generally made up of lightweight polyethylene foam, soft plastics, or silicone, and it is produced for a certain size of the foot. Then custom-made devices, they are constructed from an impression of a person's foot through computerized assessment or a foam box. So orthotics, basically, they require the prescription, which allows for the rigidity, materials, posting, angle degree of foot correction, and accommodative modification. So when structural changes, they do not improve with shoe changes or over-the-counter modification, a referral to an orthopedic surgeon or podiatrist may be necessary. So these are the foam box, and these are the custom-made orthotics. So shoes in geriatric population, basically with the age, the feet becomes flattened and wide. So about 75% of adults over the age of 65 years, they wear shoes that are too small. So we should advise older adults to have their feet measured routinely and purchase shoes that are fit well, have a sturdy heel counter, have a firm bevel sole, provide a good traction, and have a heel which is less than 6 centimeters or less than 2.5 inches high. So a wide heel that is less than 6 centimeters, it can be appropriate for the women who wear tight heel skirts and wear high heels all of their lives. But for the older adults, it is recommended to not to wear more than 6 centimeter heels because there are greater risk of falls in them. And if proper shoes and inserts that reduce the pressure, they can decrease the pain, protect the foot from the injury, and improve the function in the older adults. So surgical approach. So it may be indicated for the foot problems, which is not alleviated by the conservative methods, or when the goals are relief of pain and restoration of the function. So most podiatric surgeries for older adults, it can be performed under local anesthesia with monitored sedation. But studies have shown that poor surgical outcomes, they usually reflect the overall health of an individual rather than his or her chronological age. Now we are going to discuss with benign lesions of the foot. So the most common is the keratotic lesions. The keratotic lesions such as corn and calluses, they are caused by mechanical stress on the foot, either it is intrinsic or extrinsic. So basically pressure on the foot that leads to a normal protective physiological response, which results in hyperkeratosis. So these are the milder ones, and if they're severe, then it can lead to this. So treatment would be scalpel debridement of hardened skin surface to remove the core, which is followed by the use of topical salicylic pads. So this provide relief to the patient with the lesions revolving itself within weeks of the treatment. So it is a surgical debridement after the treatment. So plantar verruca, it is also one of the most skin disorder of the foot, but these lesions that dramatically reduces in incidence with age. So lesions are circular, punctated, flat, and commonly contain thrombosed blood vessels. So how can we differentiate it from the keratotic lesions? So what's basically demonstrate interrupted skin lines, pinpoint bleeding with debridement, and increased lateral compression pain. So treatment, it is topical salicylic acid, bleomycin injections, cryotherapy, carbon dioxide laser treatment, or surgical excision. And it must be used with caution in patients who have either reduced circulation or impaired healing history. So treatment of varicose lesions in older adults, it may require mixing approach. So treat the warts as well as treat the associated complications like hyperkeratosis with keratolytic agents such as urea. So these are plantar warts or verruca. So the other benign lesions, they are epidermal inclusion cyst, which is created by a portion of epidermis proliferating in the dermis. Dermatofibromas, these are flat, topped, raised, firm lesions, generally not treated unless located across a joint or irritated by the shoes. But the thing is that there's has high recurrence rate after excisions. Hemangiomas, they are common vascular tumors that manifest as flat top, red lesions typically seen on the plantar aspect of the foot. So these are plantar epidermal inclusion cysts. So treatment of them, if basically inflamed, unimpacted epidermal inclusion cysts, they rarely resolve spontaneously without any treatment or surgery. But treatment is not emergent unless it is desired by the patient or there is increase in the symptom severity, that is either pain or any infection. So injection of steroid medication, it leads to decrease in swelling, but it is temporarily. Then incision and drainage, but the definitive treatment is surgical excision of the whole cyst. Then dermatofibroma. These are the plantar dermatofibromas. So treatment options for dermatofibromas are freezing with liquid nitrogen, localized steroid injections, laser therapy, or shaving the top to flatten the growth. So however, these methods, they may not be effective. There are currently no known method of permanently changing the size of dermatofibroma. And occasionally a growth may shrink or disappear on its own, but it is very rare. And we already discussed that the recurrence rate is very high in dermatofibroma after the excision. Then there come malignant skin lesions of the foot. They are uncommon in foot, but can easily go undiagnosed and generally have a poor outcome. It includes basal cell carcinoma, Bowen disease, squamous cell carcinoma, malignant acral lentiginous melanoma. So the incidence of melanoma, that is plantar interdigital, is particular, and it is more common in darker skinned individual as compared to the white one, but it is not characteristically related to the sun exposure. And the characteristics of potentially malignant lesions are neolesions in the patient more than 60 years old, or any lesion that changes in shape, size, color, or diameter. So we should do the biopsy of lesions that are not responding to the conservative therapy, or any slow or non-healing ulceration of foot. So xerosis. Plantar skin, basically, they lack the sebaceous gland. So it is more common for the fissures to develop on the heel, which are resulting in dryness and increasing stress. So treatment goal for them is prevent the infections and other complications. So what we have to do, 10%, 20 or 40% urea solution, or 12% ammonium lactate applied daily after bathing. So heel sleeves or pad made up of silicone, impregnated with mineral oil or heat cups to minimize the trauma. Then eczema. So this is the eczema on the plantar surface. So inflamed skin that is not infected. So most common types in older adults are xerotic eczema, venous stasis eczema, and drug-induced eczema. So treatment would be a combination of emollients and steroid creams with or without occlusive dressings. So, onychocryptosis. So it is basically incurvation of the edge of the nail plate into the nail groove. So generally the distal portion. See, this is the ingrooving. So it can result from the long-term improper nail cutting, narrow shoes, or genetically incurvated nail matrices. So best treatment would be a partial nail avulsion or permanent matrixectomy. Paronychia. Paronychia is basically the localized infection which is caused by the nail embedding into the nail groove. So, and see, this is infection, it requires incision and drainage of the abscess with removal of the nail spicule and infected granulation tissue. Antibiotic treatment may be needed. Toes with chronic paronychia should be radiographed to exclude any underlying osteomyelitis, especially in patients who have diabetes or peripheral artery disease. Onychomycosis. It is a fungal infection of the nail plate that can result in yellow, thickened, and friable nail. And it can be a source of nail bed ulceration in patients with neuropathy. So risk factors for onychomycosis is basically old age, obesity, immunodeficiency, diabetes, peripheral artery disease, cutaneous, chronic tinea pedis, or psoriasis. So consider treating if there is pain or cosmetic concern or comorbidity like diabetes is present, in which there's break in the epidermal barrier, which can serve as a route for bacterial infection. So the treatment option includes terbinafine and itraconazole, which are antifungals. And these drugs help a new nail grow free of infection, slowly replacing the infected part. So fall risk, unintentional fall death rates among adults more than 65 years old increases from 41 per 100,000 to nearly 58 per 100,000 between 2004 and 2013. So risk factors for the falls are neuropathy, diabetes, obesity, arthritis, weight changes, pain, and fear of falling. So CDC guidelines for assessment can be found on this link. And one study, it showed a simple intervention to provide foot care fall by 36% compared with no interventions. So thank you so much, guys, for listening. And from here onward, my colleague, Dr. Arij, she will discuss the diabetic foot and other foot conditions. Thank you so much.
Okay, thank you, Hina, for this nice and tight presentation. Hello, everyone. Hello, Dr. Nadir, and thank you for this opportunity. Let me share my screen first. Sorry, I'm sorry about that. Okay, I'm going to discuss systemic disease that lead to foot disorder. I'm going to start with diabetes mellitus. The most important disease that affect foot health in older people is diabetes. As you know, about 65% of geriatric people have diabetes, and 50 to 75% of amputation in patients with diabetes could be prevented by periodic assessment, early intervention, and foot health education. Also, ocular complications reduce ability to see ingrowing nail, corns, and ulcer, and also delayed wound healing is the factor that can lead to foot disorder. Then the diabetic foot complication, vascular impairment. The clinical feature of vascular impairment is pallor, loss or decrease in pulse, dependent rubber, decreased capillary filling time in toes, and venous swelling, wrist pain, typically at night, and loss of plantar metatarsal fat pad. Also, other complications, neuropathy, insensitivity, loss of protective sensation, paresthesia. Patient also may have diminished or lost Achilles and patellar reflex, and also decreased vibratory sense and motor weakness. And all the other complication is foot ulcer, and all these complications, the vascular impairment, neuropathy, can lead to foot ulcer. Okay, the foot ulcer, the most common cause is pressure, venous insufficiency, arterial insufficiency, and neuropathy. Other common causes is tumor, as Hina said, the malignant melanoma can cause, and also polycythemia vera. As you know, in polycythemia vera patient, the patient develops secondary ischemia due to hyperviscosity of blood and platelet disorder, and also it's associated with polyneuropathy. And also other causes, improper self-care, Charcot-Marie-Tooth, and leprosy. Other systemic conditions can impact feet, hypothyroidism, heart failure, renal failure, and lymphedema. All these conditions can lead to peripheral edema, as you know, and this disrupts the flow of fluid from capillary bed to the tissue, and at the end can lead to foot ulcer. Then we're going to discuss the prevention of foot ulcer and diabetes. First of all, we need to do foot examination by clinician at each visit or at least annually, and then daily inspection also by patient or caregiver. And also management of underlying disease, treatment of peripheral neuropathy, arterial disease, and treatment of limited joint mobility, elevated plantar pressure, and also treatment of bony deformities, shock and tear. All these can decrease or reduce ulcer, foot ulcer in diabetic. And the most important part, I think, is education. Education for patient and caregiver can reduce the risk of foot ulcer and amputation. And the education available through national or regional diabetic association and at the diabetic clinics. I think this is the most important part in prevention of diabetic foot ulcer. Okay, so in foot ulcer management in diabetes, you need to do history and examination by assess location, duration, inciting event or trauma, prior ulceration, infection, if there is any ischemia, neuropathy, and you look for the wound care, edema, and also charcot joints. Also, you need to evaluate vascular, neurological, dermatological systems, and also you need to identify structural deformity and exclude osteomyelitis by doing imaging study. Other optional study you can do, plain radiography, CT, bone scan, MRI, also Doppler and transcutaneous oxygen tension. Foot ulcer management in diabetes, after we did the history and examination, after that, we need to do debridement, pressure relief, wound management, treat infection with early antibiotic, and also we can do negative pressure therapy, also called vacuum assisted therapy. It can help in wound healing, treat ischemia, manage comorbidities, and hospitalization and surgery if needed. Other disease is peripheral arterial disease. Also older adults with peripheral arterial disease demonstrate many of the same signs and symptoms as diabetic patient. In contrast, the neuropathic ulcer, the vascular ulcer, which is the vascular ulcer is actually the venous and arterial ulcer. The vascular ulcer are extremely painful. Okay. And last part of systemic disease, arthritis. Osteoarthritis common in older adults as a consequence of normal aging with chronic trauma, opacity, and deformity affecting weight-bearing joints. Also gouty arthritis, monoarticular, mainly in the first metatarsophalangeal joint. The patient may feel intense pain and erythema, and later joint damage may occur. Also, we have rheumatoid arthritis. It affects hands and feet equally, usually symmetric. Metatarsophalangeal joint become dislocated or subluxed, causing increased protrusion of metatarsal head and painful walking. All these can lead at the end to foot ulcer or foot disorder. So in summary, foot problem cause some of the most distressing and disabling conditions affecting older people. The ability to remain pain-free ambulatory is the key to successful aging. Long-term effects of common structural foot deformity, including collapse with Plano valgus, cavus foot, and equinus deformity, cause significant disability in older adults. Skin disorders of the foot are common in older adults, Complete assessment of skin of the foot is necessary to identify skin condition and potential malignancies. Also, systemic disease can have long-term effect on foot and ankle. And finally, surgical intervention for treatment of foot deformity can alleviate pain and improve function in older adults who are appropriate surgical candidates. And most surgical intervention in older adults can be performed under local anesthesia. As you know, geriatric people are sensitive to anesthetic agent. Okay. Okay, guys, do you have any question or comment before we proceed to the cases? I will check the inbox. Okay, now we have 3 cases.
Maybe just because of the limitation of the time, maybe we can skip the cases for today.
Okay, Dr. Nader.
I really appreciate this. Is also a great presentation by both of you. Thank you so much, all presenters today. As you said, it's an important topic. Thank you for explaining and showing us more information about this important.
Yeah. Okay, Dr. Nadir. Our next presentation is pain management. Will be presented by Dr. Gamila and Dr. Ragda.
No, Dr. Gamila and Dr. Tayseer.
Oh, Dr. Gamila, sorry, Dr.
Hello.
and Dr. Tayseer.
Hello, hi.
When you're ready, you can start, guys. Thank you. And thank you for listening, guys.
Hello, hi everyone. Thank you, Dr. Arij. Thank you, everyone present. My name is Gamila. Thank you, Dr. Nadir, for this opportunity. I will present the pain management in elderly. Let me share my screen first. Okay. Do you see my screen?
Yes.
Yes, we see.
So I will present me and Dr. Tayseer pain management in elderly. So first we start with pain definitions. Pain is a complex, unpleasant phenomena composed of sensory experience that include time, space, intensity, emotion, cognition, and motivation. Pain is an unpleasant or emotional experience originating in a real or potential damaged tissue. Pain is an unpleasant phenomenon that is uniquely experienced by each individual. It cannot be adequately defined, identified, or measured by an observer. Effective pain management, we know the type of pain, assess the patient's level of pain, minimize pain with non-pharmacologic techniques, add pharmacologic analgesia when needed, avoid analgesics harmful for older adults, anticipate and manage the side effect of opioids. So pain intensity scales. We classified unidimensional scales or multidimensional scales. Unidimensional scales, we have numeric rating scale. This is a scale from 0, there is no pain, and 10 is the worst pain imaginable. Faces pain scale, patient choose the facial expression that correspond to the pain. And this is particularly for the patient who cannot talk or speak well language or sensory impairment. So The face scale may be the best choice because it is relies on picture rather than the words or number. Verbal descriptor scale, no pain to pain at the bad it could be. Multidimensional scale, we have Nabeil pain questionnaires and pain disability scale. Pain in cognitively impaired persons. Observe for possible pain-related behavior and ask caregiver for their observations. Consider trial of analgesia for patient exhibiting pain-related behaviors. Validate scale, purely discomfort scale, checklist of nonverbal pain indications require training. Provide empiric analgesia during procedures and conditions known to be painful. We have 3 types of pain syndromes: nociceptive and neuropathic, or mixed or unspecified pain. Nociceptive pain due to activation of nociceptive sensory receptors, often adequately treated with the common analgesics, like somatic or visceral. Somatic, well localized in skin, soft tissue, or bone. Visceral, due to cardiac, GI, or lung injury, due to visceral pain. Neuropathic, from irritation of component of CNS or peripheral nervous system, may respond well to non-opioid therapies, respond unpredictably to opioids. Mixed or unspecified has characteristics of both nociceptive and neuropathic pain, common in elderly adults. So we have non-pharmacologic and pharmacologic therapy. Non-pharmacologic therapies include physical interventions, physical therapy, acupunctures, chiropractic, manipulation, massage, psychological education, intervention, cognitive behavior therapy, meditation, and patient educations. Non-pharmacologic therapies, patient education and involvement in decision. So teach patient to take medication properly and how to use assessment instrument. Provide partner-guided pain management training to caregiver. Cognitive behavior therapy, regular physical activity, or supervised rehabilitation for frail patients, or regular repositioning and gentle massage for bed-bound patients. Referral for an interdisciplinary pain clinic. So principle of pharmacologic therapy, besides the pain relief, the goal are improve function and enhance adherence with the rehabilitation. Individuals, the initial dose and the rate of titration in general start opioid at lowest dose and titrate slowly. But if patient is in pain crisis, do not withhold medication. Try non-systemic or non-pharmacologic therapy first, if appropriate, because we have to outweigh the benefit risk for with the patient adverse effect. So treatment with pharmacologic. First, we start with acetaminophen, particularly for musculoskeletal pain. Just a minute. Okay, particularly for musculoskeletal pain, no more than 4 grams every 24 hours. Lowers the dose by 50% or avoid in patient at risk of liver dysfunction, especially with a history of heavy alcohol intake. Know all medication the patient is taking, as acetaminophen is a common ingredient prescription and over-the-counter drugs. So, no more than 4 grams of acetaminophen every 24 hours should be administered for patients with a normal hepatic and renal function. So the normal hepatic and renal function don't take more than 4 grams every 24 hours because risk of hepatotoxicity in higher dose. So those patients with the risk of liver dysfunction and have a history of heavy alcohol intake should be treated cautiously. In this patient, the dosage should be decreased by 50% or acetaminophen should be avoided, even if you can avoid the patient if you have instead of to use the acetaminophen. Acetaminophen is commonly contained in many over-the-counter and prescription products. Therefore, knowledge of all medication that patient is taking is critical to avoiding acetaminophen toxicity. NSAID, non-steroidal anti-inflammatory, many significant adverse effect. Use of COX-2 inhibitor in elderly is better with extreme caution. If at all, in older person, use judiciously. If at all, only after acetaminophen has been tried and only in highly selected individuals. So NSAID tend to be more effective than acetaminophen in chronic inflammatory pain, but significantly higher treat to older adults, so must be used judiciously if they are considered at all and only after acetaminophen has been tried. And only in highly selected individual, significant adverse event including renal dysfunction, GI bleeding, platelet dysfunction, fluid retention, precipitation of heart failure, and precipitation of delirium limit their use in the treatment of chronic pain in older adults. So we can use NSAID with caution. Let Dr. Tayseer to complete the presenting part. Thank you, everyone. Thank you, Dr. Nader.
Hello, everyone. Thank you, Dr. Nader, for this opportunity. Thank you, everyone, for listening today, and thank you, presenters, for the great presentation. I'll share my screen. Okay. Jamila, can you continue sharing the screen, please?
Okay, I will share. Right.
Okay, I'll continue talking about treating moderate to severe pain. Treating moderate to severe pain to estimate opioid requirement, conduct a trial of short-acting opioids. Treat continuous pain with 24 hours opioids in long-acting or short-acting or sustained release formulation. To cover breakthrough pain, combine a fast onset medication that have short half-life. Breakthrough pain typically require 5% to 15% of the daily dose, offered every 2 hours orally. In general, different opioids are similarly efficacious. Cost and route of delivery can help guide the choices. Combating fear of tolerance and addiction to opioids. Avoid withdrawal symptoms by tapering carefully over days to weeks. If rapid upward titration is required to reduce pain, suggestion that tolerance has developed, evaluate the cause of pain, including searching for new pathologies and exacerbation of known sources of pain. Consider non-physical cause of pain. There is limited course tolerance between opioids, so when switching between patient from one opioid to another, reduce the dose to 50% or 65% of the equivalent dose. Fear of taking opioid therapy for a lot of patients may have this fear and losing their effectiveness in the future. So they may also have fear of addiction, and it's a very, like, fear of addiction is a major obstacle in medication for older patients. So a frank discussion of these concerns may help to alleviate their fear. Managing the adverse effects of opioids, constipation, educate patient about probable need of long-term laxative treatment. In most cases, start with a stimulant laxative. Encourage exercise and hydration. Consider methyl naltrexate for patient with opioid-induced constipation, despite laxative therapy. Opioid-induced constipation is due to multiple mechanisms, including like hydration, decreased GI tract secretion, decreased motility in the GI, although tolerance develops fairly rapidly to other side effects of opioids, such as respiratory depression and sedation. Constipation usually complicates opioid use in the duration of treatment. So there's also nausea, vomiting. So evaluate for reversible causes when try a different opioid or treat with chronic antiemetics. Okay, next.
Do you see my screen, guys?
Yes.
Yes.
Sedation, fatigue, mild cognitive impairment. So educate the patient that these changes generally subside days, 2 weeks after dose adjustment. Warn against driving or operating heavy equipment when medication is initiated. Warn of risk of fall. For incessant fatigue, try stimulants such as a low-dose methylphenidate or rotation to a different opioid. Respiratory depression and titration, use naltrexate sparingly and at the lowest dose and titrate carefully. So respiratory depression is a feared complication of opioid therapy. Older persons with history of lung dysfunction, particular risk when opioid doses are increased too rapidly. So naltrexate and opioid receptor antagonists can reverse the opioid-induced respiratory depression. However, when it is given to patients who have treated chronically with opioids, it may participate in pain crisis in withdrawal symptoms. So experts suggest that holding naltrexate unless patient's respiratory rate decreases to less than 80 breaths per minute, or oxygen stimulator at below 90%. Opioid medication, non-opioid medication are TCAs, tricyclic antidepressant, are off-label and are the best studied drugs for neuropathic pain. treating post-herpetic, like they're used for treating post-herpetic neuralgia and diabetic neuropathy, has been exhibited in numerous placebo control studies. However, they're associated with a lot of anticholinergic side effects in older people. Optimal analgesic require treatment of depression. Like SSRIs are less well studied than TCAs as analgesic, but they are better tolerated in antidepressant doses. Antiepileptics are commonly used for neuropathic pain, such as carbamazepine, pregabalin, or gabapentin. They are commonly used for treatment of neuropathic pain. Corticosteroids are useful as adjuvant for neuropathic pain and pain associated with swelling, inflammation, and tissue infiltration. Cannabis and cannabinoid, the efficacy of and safety profile in older adults is uncertain. In general population, limited evidence suggests that cannabis may elevate neuropathic pain, but this may be associated with increased risk of motor and vehicle accidents and psychotic symptoms and cognitive impairment. Does anyone have any questions before we go to the cases? Okay, this is case 1. I'll be reading out and give you some time to think about it. So we have a 69 years old man present to the office for bilateral knee pain for the past year. The pain is worse with movement and is relieved by rest. He has history of type 2 diabetes and he takes metformin and multivitamin. Physical examination shows pain, crepitus, and joint movement, stiffness, restricted range of motion for both knees. X-ray of the knee shows irregular joint space narrowing, subchondral sclerosis, osteophytes, and several subchondral cysts. So which of the following is the best medication? Okay. So yeah, I see a lot of people. So it's ibuprofen. And the next case is a 70 years old woman comes to the clinic complaining of right side chest pain for 2 months. The pain is burning in nature on the right chest wall and back. Patient had rash in the same region prior to the onset of symptoms. Her medical history, she has a history of breast cancer treated with surgery and chemotherapy. She has hypertension and type 2 diabetes. Her pulse is 80 per minute. Blood pressure is 135/80. Temperature is 37.2 centigrade, and her respiratory rate is 14. Physical examination, chest exam shows no rash or swelling. There is a band-like area of hyperesthesia on the right side. Lung and heart sounds are normal. Back examination shows no deformity or focal tenderness. So which of the following is the best medication to manage this patient's pain? Okay, this patient has a neuropathic vein, so we're gonna give her gabapentin. Wait. Okay, thank you everyone for listening. Thank you. Does anyone have any questions? Okay, if no one has any question, thank you for listening, and yeah, we'll go back to the moderator.
Okay, everyone. Thank you both Mila and Tayseer for great presentation again. Thank you. Any questions?
Okay, if there's no question, our next presentation is SPSS, who is presented by Dr. Ragda, Ahmed, and Ali Awadallah.
Yes.
When you're ready, guys, we can start. Thank you.
Yes. Hello, everyone. This is Ali Awadallah. Thank you all for listening. Thank you, Dr. Nadir. Thank you, Dr. Arid. I hope you all can hear me. I will start with sharing my screen. Is it clear for all of you?
Yes.
Yes.
Yeah. So,
Yes.
so SPSS statistics. SPSS stands for Statistical Package for Social Sciences, and was launched first in 1968, and then it was purchased by IBM in 2009. Thus, the proper name for it now is IBM SPSS Statistics. IBM SPSS Statistics is a very popular program used for statistical analysis. It was used for behavioral science like psychology and social human services, but it's also used in a different field of statistics. The software works similar to Microsoft Excel with a spreadsheet style, entry field, and easy to use toolbar. SPSS is a software for editing and analyzing all sorts of data. So how to download SPSS? SPSS is available for with 30 days free trial from IBM.com. You have to go to IBM.com, create an account using your name and email address and some basic questions. After that, you download the program, install it in your computer, and log in to it using the IBM ID you have. Now, let's see how to use the SPSS. First of all, we have to know that the biggest strength of the SPSS is its user interface, which rely on drop-down menus. So we'll start by opening the software in the computer. After opening the software, we'll find two views. One is the data view and the other is the variable view. Here is a screenshot of the view you will see after you're opening the software. In the left lower corner, you see two options, either data view or variable view. Now we are in a data view. In a data view, each row here represents one participant, subject, or case, and each column here is dedicated for a single variable or type of measurement. Here is the variable view. In a variable view, each row here is dedicated for one variable, and each column here is dedicated for the properties for this variable. So we'll start by setting our variable. We are still in a variable view. First of all, we'll add the name of the variable. the name can be gender, weight, age, or any other type of variable you want to add, but you have to make sure that the name cannot begin with special character or number, cannot have space, and each variable must be unique, different from other variable. After putting the name of the variable, we go to the type of variable here. If you click on type, an icon like this will appear, so you have to categorize the type of variable. Is it numeric, is it strings, or other type of variable? For example, if you put here the name of variable like age is a numeric, so we'll choose numeric. If we put the name of variable age is also numeric. If we put the name of variable is the name is string, because we have to add text, so it is string. We'll click here. This is the second properties of the variable. There is other properties of variable like width, which you can adjust the maximum number of character for each variable. In the label, we can add more description for the name of the variable. For example, if you put the name here, weight, in the label here, we can add more description of this variable. For example, you can put weight in pound, weight in kilogram, and like this. If we put here the name of variable is age, we can put here in label more description of age. For example, age in years. Other important properties of variable we add is the value. If you click on value, an icon like this will appear. So if the variable, for example, gender, have more than one value, gender can be male or female, we can assign number for each value. For example, 1 can be for male, 2 for a female. And this will make data entering in the next step more easy. We have also other different type of we have other important feature of properties like measurement. For each variable, we have to choose from 3 different measurement type, either scale, ordinal, or nominal. Scale for quantities like birth of weight will add number, so it is a number, so it will be scale. Nominal for non-gradable variables like gender, and race, and religion, it is a nominal. And ordinal for example, mild, moderate, severe, it is gradable but cannot be in quantities, so it will nominal. So we have 3 types of measurement in SPSS, either scale for number, ordinal, or nominal. There is other important properties like decimals, column, alignment, measurement, roll. And if you start practicing the SPSS, will be more familiar with this. Now I have example here of a table with a variable view. If you see here, I put the name, for example, interview ID. The type, it is a numeric because we'll put number. And the type of measurement is nominal. Here name, it is a string because we'll add text later on, and it is nominal. Here age, it is a numeric, and it is scale. And here our basic question in the study, for example, I put here rice, and the label here, more description of the name. Did you eat rice in the past 3 days or the past 7 days, like that? And it is ordinal. So after putting our variable here, we click on data view. After, as you notice here, after we going to data view, our variable we add come here into column, interview ID, name, gender, age, and our question here, basic question in the study. After that, we will start adding our data, entering our data one by one, starting from interview ID, 1, name, gender, age, our question, yes or no, until we finish all entering all our data. After entering our data, the next step will start analyzing our data. And how to analyze the data will be discussed by my colleague, Dr. Ragda Ahmed. you are here, please continue.
Hi, this is Ragda. Can you stop sharing your screen, please, Dr. Ali?
Yes, yes, sure.
Okay.
Go ahead, Dr. Ali.
Okay, just give me one moment. All right, this is Ragda Ahmed, and good afternoon. And I'm sorry for any noise that you guys may encounter. I'm going to start to speak about the analysis function in the SPSS. Here it shows a set of the data in the data view. You can see that I have like 12 subjects, and these are different variables, gender and height and weight. So let's start. As Dr. Ali mentioned before, everything in the SPSS is just in the pull down menu. So when we go to the upper tool here, we're going to find the analysis. And the easiest thing in analyzing data is to count how often things occur. So in the descriptive statistic, we're going to choose the frequencies here. So we open the analysis, going to show us a menu. And when we choose the descriptive statistic, going to show us a sub-menu. And we will choose the frequency. And pop this frequency window gonna pop up. On the left side, we want to show our variables, which is the gender, height, and weight, and the ID. And we can choose which of this variable we want to analyze. So I'm going just to press on it. Oh, sorry. Oh, press on it, and then we're going to press on this arrow, and the variable is gonna go to the right side. And then I'm going to press OK. Then this is the way the frequency table is going to show. It shows here. On the gender side, we have 12 valid values and no missing value. On the height, you can remember when I have like 12 data, there were 2 missing. So we have scored the valid ones, it's 10, and the missing were 12, and the weight exactly. And here, the way it's going to show on the table, the percent, it means the percent column, it represents the sample size of the data, and the valid is the actual data that who actually have a score and have actually value. So in gender, we have 12 data, and we have in the variables we have value for 12 people. But in the height, we only have for this 12 data we only have 10. So we have some missing. You will show this in the next screen. Here, what I said, like the valid sample size is the number of participants for whom we actually have a score, and the percentage column for the total sample size, and the valid percent column for whom we actually have data. When we don't have missing values, like for the gender one, the percent and the valid percent will be exactly the same. But when we have a missing value, there is something else going to show called missing system, in which the percent and the valid percent are different. We usually, when we report for statistic analysis, we just use the valid percent, unless if you have a precise reason to report both of them. See? This one in the heights, when we have like 2 missing data, it shows the missing system, and the percent and the valid percent, they wasn't the same. Another thing that we can do using the SPSS, we can view our data in charts. So we're going to go at the same exact part where we show the analysis, and then descriptive, statistic, frequency, and this table. Remember this table, guys? Then we're going to choose charts. We have different chart, bar chart, pie chart, and histogram. This is how the chart looks. This is the bar. This is the histogram. Sorry for this, guys. And another thing we can do the statistic, the mean, median, mood, and the standard deviation. And this is the table for the statistic. You guys can see the mean, the standard deviation, the variable. So as a summary, usually when we choose the statistic, the graph, just one moment, guys. when we choose the statistic and the graph, the bar graph or histogram or the pie graph are the statistic when we choose the standard deviation and the mean or whatever, we have to make sure that they are convenient to our data. So when we use the nominal variables like gender, we usually report it with frequencies and the bar charts. And when we use the scale variables that have the ratio and interval like heights, we usually report it with the mean, standard deviation, noise. If there is any question, concern, or comment?
Okay.
Again, thank you so much, Dr. Ali and Dr. Ragda, for that presentation. Thank you so much. This is awesome. Great. Hope you this will help all of us to understand some of the basics of this SPSS, the statistics. And it's one of the tools that we can use. There are other options. For example, Excel itself or Google Sheet can do some of the simple statistic methods. Or we can use other programs that are paid, or maybe there is another program that's free. One of them is called R. It's like a language or coding. It's similar to SPSS, but you use Word instead of clicking on the drop-down menus and so forth. Maybe we will talk about it in the future. Thank you so much for your presentations. Guys, any other questions?
Okay. Thank you, Ragda, and Ali for this nice and interesting topic and presentation. Our next presentation is the last presentation is leadership skill. Will be presented by Dr. Nabeil, Himat, and Ahmed Abdel Nasser.
Good afternoon, everybody. I'm Dr. Nabeil. Can you hear me? Sorry, do you anybody hear me? Hello?
Yes, we can hear you.
You can hear. I can hear.
Good. Okay.
But your voice is interrupted.
Let me share my screen. Okay. My topic today is going to be about leadership skills. Okay. This is Dr. Mohamad. Okay. Leadership function of knowing yourself, having vision that is welcome, trust among colleagues, and
Hello, Dr.
leadership potential.
Dr. Nabeil, your voice is interrupted.
Leadership about to be a leader, and it can be summarized in this format: having a leadership and tolerance.
Hello, Dr. Nabeil, if you can hear us.
Control.
Hello.
Emotional stability and maturity.
Dr. Nabeil?
Yeah.
Your voice kind of muffled and echoing. Can you double check your mic? Sometimes that happens when you have some interrupted internet connection, or the mic itself, or the video.
Also, you can be near to your router. I think you have poor connection. And check your mic also.
So while Dr. Nabeil is trying to fix the voice issue, so the leadership skill is important, and we want all of you to learn something about it and learn the skills, because hopefully when you enter the residency, you're gonna be working in teams. So for the first year, you're gonna be the junior in the team, and you will have a senior who leads the team, usually one senior for 2 or 3 interns, which the first year. And then the second year will tell you which patient you want to see and when you're going to report, and when you go when you do the rounding in the morning, present your cases. So for the first year, you're going to be receiving some instructions or orders, if you will. Then comes the next year. The second year, you will be the team leader for the juniors. So we want you to be ready from now. When you get that position, you will be able to lead your teams as far as what they're supposed to do and how you can report to the attendant, for example, how you can help them do research, how can you lead them to, let's say, presenting into conferences or selecting their subspecialties, something like that. So, and this will help you down the road, hopefully. Thank you. Maybe if you can try again.
Hello, Dr. Nadir.
Yes.
Is it clear now?
Yes.
Looks like I have some connection issue here.
Sure. Nice, better.
Okay. Okay. Is my voice clear now?
Yes, clear.
Yes.
Go ahead.
Okay.
Yes.
Definition of leadership. Leadership is a function of knowing yourself, having a vision that's well communicated, building a trust among colleagues, and taking effective action to realize your own leadership potential. There is some trait supposed to be in a proper leader. They should have a high energy level and stress tolerance, to be a self-confident, having an internal locus of control, emotional stability and maturity, have a personal integrity, have a socialized power, motivation, and high achievement orientation. This is some brief description about each one. A high energy level and stress tolerance means he has the ability to cope with the hectic schedule, unrelenting pressure, difficult situation. He had to be composed and calm under stress, problem focused, confident, and decisive. The second one about self-confidence, I think it's clear ability to influence others, taking initiative and be persistent, optimistic, and decisive in crisis. Internal locus control means he had supposed to have ability to take responsibility for own action and learn from his own mistake. He should be future-oriented, proactive, believe events are determined by our action, not by chance. Emotional stability and maturity is that he is able to care about other people, control his own emotion, taking criticism constructively. Also, he's supposed to be aware of own strengths and weakness, focus on self-improvement, and keep high moral standards. About personal integrity, that we have to be able to be consistently honest, ethical, and loyal to the follower, keep promises and confidential information, and set an example with his own behavior. Socialized power motivation, it is the ability to participate, coaching, exercising power for the benefit of the other. This power used to build up the organization and create a team pride. And finally, the high achievement orientation. The leader should be able to set a challenging but realistic goal, organize tasks, perform efficiently, and take specific action plans. achieve this kind of drive, there are some skills to be learned by the leader. Technical skills like he's supposed to be knowledgeable about the project, the method of achieving it, processes, technique, and equipment. It required to have a good memory, orientation to details, and rapid learning of technical material. Interpersonal skills, you have to be knowledgeable about the human behavior, feeling, attitude, motive of the other. Also have an ability to communicate clearly and require empathy, social insight, and diplomacy. About conceptual skills, should have a good judgment, learn to be a foresight, intuition, having creativity, and the ability to find meaning in face of ambiguity. Requires also analytical ability, logical thinking, concept formation, inductive and deductive reasoning. Social intelligence. Social intelligence, that means ability to identify social requirements for particular situation and select appropriate response. Require a social perceptiveness and behavioral flexibility. And systemic thinking. Understand that a change in one part of the organization will affect the other part as well. Appropriate reaction to anticipate it. Consequence can counteract these effects and require awareness of how different parts of the organization are interrelated. And finally, the ability to learn. Ability to learn from the experience and adapt to change. Supposed to be flexible enough to learn from the mistake, change assumption and beliefs, and refine their mental models. Require self-awareness, open-mindedness, curiosity, and routine feedback about strength and weakness. As a conclusion, the leadership is a process. It's not a position. It's to combine the power and influences into the process of work, always to keep the bright side of yours and improve the dark ones. Enhance your skills in perceiving, managing, using, and understanding emotion. Leadership and leadership is indispensable. And always keep the followers close and improve them through effective delegation. Also establish effective group and team to help you achieving the overall goals and understand the pros and cons conflicts and apply the appropriate technique to resolve them. So leadership based on inspiration, not domination, and on cooperation, not intimidation. Okay, thank you very much.
Thank you again for this excellent presentation. And we have the second presenter.
Thank you, everyone. Thank you, Dr. Nabeil, for this great topic and presentation, and all of you guys. I think, Dr. Nadir, we are done for our agenda for today. And now we are going to know if any project update or do you have any question or comment, guys? I can do my question if you don't have mine.
Right.
Do you have any question, guys, or any comment? Okay, let me share my screen. Okay, let's see. Okay, guys, the cases for food disorder. Case 1 is no, case 2. This case 2. Just a minute. Okay, case 1 is a 73-year-old woman seen because she can no longer manage self-care of her nail. History type 2 diabetes, medication metformin, lisinopril, atorvastatin. Examination show global nail dystrophy with nail of both feet thickened and discolored. 1+ dorsal pedal pulse, absent medial pulse, profound neuropathy, periodic acid strip stain of nail tissue, confirmed presence of Terophenema rubrum, dermatophyte infection, and lab finding hemoglobin A1C of 6.8, normal liver and renal function. Which of the following is the most appropriate management strategy? A, no treatment, topical antifungal therapy, oral antifungal therapy, or trim and thin nail. What do you think, guys? Yes, the correct answer is C, oral antifungal therapy, because this is onychomycosis, fungal infection, is treated with tripanfene, griseofulvine, fluconazole or itraconazole also. Okay. So, second case is case 2 is a 76-year-old woman. A 76-year-old woman is seen because for the past 4 weeks she had pain in one heel when she rises from a seated position or bed. She does not recall any trauma. The pain is worse when she's barefoot and often improves with walking. The pain resumes if she on her feet for a long period. History. High cholesterol and hypothyroidism, both well controlled. Examination, pronounced discomfort at the medial calcinial tubercle and pronated but symmetric bilateral stance. Radiography shows small infracalcinial cystosis, but no clinical fracture. Which of the following would be the most appropriate initial treatment? Relative offloading with Walker put, surgical excision of plantar calcinial exostosis, cushion show insert with heel left and medial arch support, or injection of plantar heel with platelet-derived growth factor. What do you think, guys? Yes, guys, most of you choose C, which is a correct answer. C, because this plantar fasciitis and the cushion shoe is like a pillow to the foot. It can absorb the impact or any trauma. Okay, the last case is a 63-year-old man. Is seen because he had brain wound on the plantar foot. He does not recall when it first appeared and had no symptoms of claudication. History type 2 diabetes, 40-pack history of smoking. Examination show normal temperature, blood pressure 128, 75, 77, and heart rate 76. He appeared well. The wound at the plantar first metatarsal region is 1.5 centimeter in diameter and appears to extend through subcutaneous tissue. There is thyroperillant range, no evidence of ascending cellulitis or ischemia within the foot. Trace peripheral pulse, absent protective sensation, and also recent hemoglobin A1C was 7.4. Which of the following is the most appropriate management plan? A radiography and admission to facility for intravenous antibiotic therapy, debridement, radiology, and the offloading show, vascular consultation, consideration for partial foot amputation, or technetium-99 bone scan, hyperbaric oxygen therapy. What do you think, guys? Yes. Yeah, yes. The correct answer is B, debridement, radiography, and offloading show. The offloading show is a show used in a diabetic patient, and those for who have a risk for neuropathic ulcer or food disorder. Okay, thank you, guys. I hope you enjoy our presentation for today.
Thank you so much, Dr. Arif, for the great presentation and the cases. Thanks, everyone. Any questions of all these presented topics so far? If you do, please raise your hand or jump in and let us know. You can send it through the chat or you can send an email. But basically, we want to discuss some of the products. If you have new ideas, please let me know. How about the updates? If anyone has any updates about their own product.
Dr. Nadir, this
Yes.
is Sushma here. So we just started the mobile app and the health behavior project. We had a meeting this week, and we will be starting the project and the data extraction, everything from next week. Just wanted to update you. Thank you for the opportunity.
You're welcome. Which topic was that, or which project? If you remind me again.
It is the mobile app and health behavior and alcohol project.
Sounds good. Thank you so much for that.
Thank you.
Yes. And our updates about other products going on.
Hi, Dr. Nadia. This is Pushyami. So I also want to update about the current project. So we are working on the suicide during and before the pandemic. We were working on all the age groups. We were able to extract the data, and last week we had a meeting where we assigned ourselves, every member got their tasks. So we finished with the results, and from there we'll be going for the next process, like introduction and discussion and conclusions. Yeah, just one update about it.
Thank you so much. This is great too. Also,
thank you, Doctor.
For the updates. Any other projects going on or updates? I got some emails and I'm gonna reply soon about some of the questions in the coming days. Excellent. So the next steps, I'm gonna try to make sure every one of you is involved in some projects. If you are not involved, or if you have ideas, let me know. If you are not involved in some of these projects, let us know also, so we can assign you to some active projects. One of the things that we can do as fellows, we can work together. So let's say I had an idea about a new project. So you go to the app at the right lower corner here. You just click on the project update. The plus sign, if you add or click that, it will give you a form. You can update or add your new idea. It will be listed here. So if you want to join some of these active projects, you can do that. These are the working on projects. Some of them maybe did not start yet. So maybe you can join if you want to work on some of these new ideas. So there are two options to use the project, what we are doing here. This is one way to communicate. The other way is to send me an email, and if you want to create a project team, we can work on that as well. The idea is to get all of you at least involved in one research project. We want you to understand the concept from A to Z. If you can apply that, you get involved in that. Hopefully, in the future, when you start your residency, you will be able to think about some research projects, and you can carry on and present in conferences and so forth. This can be also applied to other disciplines like dental. We have dental graduates, and we can also work on that the same way. No other questions. I sent you an email, all of you, regarding the presentation skills that we talked about in the week last week or the week before. How to use presenter mode or coach mode using Microsoft. So I want to make sure you follow that. So if you go to the ad again, when you start in the main page, you will have some link here. Let's say, I'm gonna just put an example. For example, if you log in, you will have the link. You click on that, it will open a file, slide file. You can work on that, and you can use a Microsoft website, and you're gonna just practice and see if you can improve as far as the filling works or your speed of presentation, and you can repeat that. When you feel comfortable, try to record that. There are different ways to record. You can record on your phone, you can record on the computer, save it as a file and upload it, let's say, to YouTube. You can save it as a private video, but you can share it with someone. So to share it, you can share it with your fellows in the group, or we assign everyone, we assign one fellow to look at your work. So it's gonna be like a pair of two fellows each. So you can give your feedback about what you see, and they can give you feedback as well. Hopefully this will work fine for all of you. If you have questions, if it's unclear, let me know. Thank you.
Thank you, Dr. Nabil. Thank you, everyone.
Thank you. So I'd like to thank all the presenters, the team today, and I'd like to thank everyone who attended, and for those who didn't come to the meeting, we understand you have some other obligations. So if you have time to look at the video and work with your team leaders, sounds good. Let's see if we can work on next week agenda. So for next week, the red team will be working on these topics. And again, I put the names of the fellows in the team. And either it's Dr. Hadid or someone might be there to lead the team organized the task. Basically, I put these names for the topics. The first topic about sleep in oral adults, second topic polypharmacy, and then we can continue on the demo as far as SPSS, how we do t-test and so forth. Maybe we can also talk about how we identify conferences or meetings so that we can target them and submit some of our work there. If you have questions, let me know. If you are one of these names listed, you are not able to communicate with the team leader. If you are able to, also just confirm and work on your presentation. Thank you so much. Thank you, everyone. And have a wonderful day. Have a wonderful night, wherever you are. Assalamu alaikum. See you next week.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you, Dr.
Thank you,
Nader.
Dr. Nader.
Have a good
Thank you.
Thank you, Dr. Nader.
Thank you, Doctor.
Have a good weekend.
Good weekend.
Thank you.
Thank you, Dr. Nader.
Thank you very much.
Thank you, Dr. Nader.
Have a wonderful day.
Thank you, Dr. Nader. Thank you, everyone.
Thank you, Dr. Nader. Bye.
Thank you. Bye.